Thanks everybody for joining. This is Carol from the STS. This is my new puppy dog, Hank. Got him at the shelter on Saturday, and he's a very good boy, and he's the newest member of our STS team. So just wanted to introduce you to him. Leanne is gonna run the show for us today. And, oh, go back so Dr. Jacobs can see my new puppy. There he is, Dr. Jacobs. This is Hank. Okay, we're going to get started with the aorta section today. We have on the call with us from STS, Leanne, Emily, Melinda, Chastity, Leslie, and myself. And Dr. Jacobs has joined us as some backup. And then we also joined us is Janet. And then from IQVIA is Joe. So thanks everybody for joining. And we're gonna get started here. I'm gonna hand it over to Melinda. Oh, let's go through this slide real quick here. Today is April 26th. We're going to continue with the aorta section and maybe get into the post-op, post-operative event section. Melinda will take lead on the aorta section, and then Chastity can take over for post-op, and Melinda can tag team when where she's going to be able to provide some additional clarification. And then hopefully next week or May 3rd will be our anesthesia, and that may be our last upgrade webinar. Again, these are all recorded, so if you need to go back once the version goes live for January 1st, these will be available, and we'll make sure to remind you that they're out there if you have questions or just want to review them before you start collecting the data. Next slide, please. Okay, and now we're going to hand it over to Melinda, and we're going to start with the open surgical descending thoracic section. Melinda.
Hi, good morning, everybody. From Pacific Standard Time. I'm sure you guys, it's probably about lunchtime where you're at or later. So anyway, we're going to start with the surgical descending thoracic aorta or thoracoabdominal procedure. So these are procedures that involve the descending thoracic aorta or the thoracoabdominal aorta. So if your patient had an open surgical procedure that involved those parts of the aorta, then this is the section you would be filling out. We want to know the proximal location. So where did this procedure begin, basically? And you can see there's many choices here. Sort of last week, we went over the graphs in the adult training manual currently that show the pictures of the zones and how the definitions of each zone to help you identify the locations. So you would choose your proximal location. Then the next sequence wants to know, was there intercostal reimplantation done during this procedure? This may or may not be done, so you have the option to answer yes or no there. Then the next question wants to know the distal location. So this is the distal extent of the aortic intervention. And again, you're picking zones where that distal zone or location was. Then we move on to visceral vessel intervention. So during this procedure, did you have any of the visceral vessels that were revascularized, either by sewing vessels to the graft or reimplantation or using a branch graft? And so it goes through each of the vessels, the celiac, the superior mesenteric, the right renal, the left renal. And then for each one of those vessels, it asks you what type of intervention was done. So, for example, if they did the superior mesenteric, did they reimplant this? Did they put a branch graft on this? Or did they do no intervention to this vessel? And so each one of them, the same questions as you're going through. The next section is endovascular procedures. So these are not open procedures. These are catheter-based procedures where a stent is implanted in the aorta, most commonly called TEVARs for the most part. That's what we're looking for here. So thoracic, endovascular, aorta repairs. Now, in the adult world, and I'm not sure how this will play out in your world, but if the CT surgeon is involved in the TVAR, because a lot of times these TVARs can be combined with vascular surgeons. So if the CT surgeon participates in that procedure, then we want them to enter into the adult database. I'm not sure again how that would work for you guys, but I'm assuming it would be the same concept. We do not include EVARs, so if it's a standalone endovascular, just an abdominal procedure, those don't go in. So we're basically looking for thoracic aortic procedures that are done endovascularly in this section.
Hey, Melinda, it's Carol. Did you want to talk about what the difference is, or how you would decide what is thoracic and what is abdominal?
Well, the thoracic, generally, if it's above the diaphragm, we're going to enter it into as a thoracic abdominal. It could extend a little bit lower, but if it starts above the diaphragm, we have some pretty nice diagrams. I'm like a very visual person, so we have some really nice diagrams in the adult training manual that, again, we talked about last week. We will be getting those diagrams into your manual too to assist you. I don't know, Carol, should we show a diagram or should we?
Yeah, let me see if I can pull it up pretty quick. I might just need to or if I don't know if Leanne has it open or not. Hold on one minute.
I've got the adult training manual open. I don't know what's the.
Good.
If you look at like, let me find a sequence number here to help you. Like, go to maybe 5015 sequence. There's a nice diagram there.
Yeah, 5066. I don't know if that's what you're. Oh, I don't know why that happened. Why is that?
There's kind of a diagram there that.
I don't know what's happening. Hold on. Why is that happening? Let's try this again. Okay.
Up a little bit further.
Down 51.
5015. It's going to be way up above that.
Okay.
Picture.
There you go.
Yeah. So make that a little bigger.
Yes, ma'am.
So you can see here where you've got, and it'll just point like we've got the root starting, and then you go to the sinotubular junction, then you're going up to the ascending, you see your arch vessels there, then you're going into your arch. So then you're starting to go down into the descending thoracic, and then you're going further down into the abdominal aorta. So somewhere above the diaphragm, below the arch, starts your ascending, coming down, and then your descending is just distal to the isthmus that extends to the diaphragm. Usually below the diaphragm, you're getting into the abdominal aorta. So
I think this is where your renal arteries are taking off, right below the diaphragm there.
Mm-hmm.
So the diaphragm are those two lines that are on the side of the aorta, about just at the bottom third of the screen. And then then it will be your descending aorta, or I'm sorry, and then it'll be your abdominal aorta. And then the what's coming out of the abdominal aorta there, I believe that those are your other arteries.
Yeah, and if you go to sequence number 5045, we've got all the vessels coming off.
There you go.
A nice picture of that, which is a really nice picture, where you've got your celiacs coming off, your superior mesenterics, your renals. Kind of a nice picture of all the vessels that are coming off. Thoracic going down into the ascending and eventually hitting the abdominal aorta.
And this is all your abdominal aorta, right? Where all of these vessels live. The phrenic arteries, the suprarenal, the renal arteries.
Mm-hmm. Yeah.
Thanks, Melinda.
So I thought I saw a question from our chat. Somebody, is that, is it Leslie? Okay. Can you touch on which operation type we will choose for these as we've eliminated interventional cardiology?
Yeah. So these would be performed by the surgeon, and I'd have to go back up. This is going to be in a
TVAR.
yeah, a car. I think the operation types they have for congenital.
Oh, their operation type.
Yeah, Cassidy, did you want to help with Leslie's question?
I mean, if these are going to be done by a surgeon and their major vessel, it's a procedure done on the aorta, then I'm assuming it just depends on if we use bypass or not.
That's right. Yeah, I agree.
All right. So as we go through the endovascular procedure, and I said most of the time this is a T-bar. This is what you're going to see how it's going to be documented in the medical record, in the op report. So the access, they want to know the access for the percutaneous procedure. Was it femoral, iliac, abdominal aorta? You've got all kinds of choices here for your access for your T-bar. Some of these T-bars can, they can open. Most often these are percutaneous, meaning that they are a stick, an external stick, and usually in the groin. But sometimes they will have to use other types of access because of groin issues or inability to access that, or it's too small for the devices that need to be implanted, this and that. So that's why there's lots of other different choices there. Okay, so then we go into the proximal landing zone. So this is the area of the aorta that's closest to the heart where the graft is located. So this is your most proximal site where you're going to put this stent graft. And again, we have the choices, starting with below the STJ, going all the way to zone 11. And again, we have a nice diagram that will assist you with that. I will tell you, as I said last week, a lot of surgeons will not tell you the zones. You know, I distal at zone 10. Well, that doesn't happen very often. Most often what happens is you're reading where he's proximally putting the stent graft, and then where he's deploying it and where it covers. So a lot of times you're not going to see the word zone 3 or zone 4. You're going to have to see I've placed this mid-ascending aorta to celiac or celiac to superior mesenteric. So you're going to see the descriptions of these zones most often in the op note, as opposed to the actual words like zone 7. And it takes some getting used to. I still struggle with it at times because some op notes are more challenging than others. But as I mentioned, we do have the worksheets, the aorta worksheets that currently we use in adult, which we will definitely be provided for the congenital participants too, so that the surgeons can, if they so choose to fill those out, they're a great help to the data managers. So the next question is the distal landing zone. Again, same question, same discussion, same answers basically. And then they want to know, did you do an ascending T-bar? Now, basically, this is to identify whether a stent graft was placed in zone 0, which is a region spanning from the sinotubular junction to the innominate artery, that was dedicated as sort of an off-label stent, or kind of like an investigational device. I don't see this done that often, but you might see it. And so there's a question for that if you do see that. Okay. Next, we're going to talk about arch vessel management, and this quite often happens during a T-bar. And it goes through each of the arch vessels and talks about how they were managed. So the choices are native flow. So there's no direct endovascular intervention on the vessel that was performed to improve blood flow. So if the artery is left intact and continues to receive blood from the native aorta in the normal manner after the endovascular procedure, then native blood flow is selected. The second choice is endovascular branch graft. So this could be an open or a covered stent that is used to hold the margin of the stent away from the orifice of the branch artery and preserve a channel for branch artery perfusion. So if the artery is instrumented with an endovascular branch graft extending from the main body of the aortic endograft, so you've put your aortic endograft in, and now you're putting a stent graft into the innominate, then you should select endovascular branch graft. The third choice is endovascular parallel graft. These are covered stents in aortic side branches parallel to and outside the abdominal or thoracic endograft. I don't see this one used that often. So if the artery is instrumented with a separate endovascular graft that does not extend from the aortic endograft, so this one doesn't actually touch the aortic endograft, it's just sort of parallel to it, then you would select endovascular parallel graft. The fourth choice is extra anatomic bypass. So this is a bypass, refers to any bypass graft that is placed outside the normal anatomic vascular pathway to provide blood flow, following or as part of the strategy. Sometimes these are performed in staged fashions, and we'll talk about that in a minute. So an example would be bypassing an arch vessel originating from the ascending aortic graft using a separate prosthetic graft. So sometimes we have staged procedures for T-bars. So like day one, they might do debranching of the arch vessels. And, 2 days later, they go in and do the T-bar as a hybrid procedure. So sometimes you'll see those extra anatomic bypasses done as stage type of procedures. The last choice is fenestrated. Fenestration refers to the creation of a hole within the stent graft. I don't see this a lot, but it can happen. So if the artery is covered by an aortic endograft with a fenestration or like an opening in the endograft corresponding to the location of artery and allowing continued antigraft flow into the artery via the fenestration, despite endograft coverage, then fenestration should be selected. And then the last choice is no flow restored. So there was no flow restored to this particular arch vessel. This can be challenging, but the more and more that you read op notes, the better at it get. I've discovered for the years, it's fairly challenging in the beginning. And it still continues to be challenging. So not going to tell you that this is easy, because it's not easy, and I still struggle with it. And a lot of the adult data managers who have been doing this for quite some time still struggle with it too. So once we do the arch vessel management, then we move into the visceral vessel management. It's the same exact answers: native flow, endovascular branch graft, endovascular parallel graft, extra anatomic bypass, or no flow restored. It has there's a few like extra questions under the celiac and the renal. So for example, if you use an extra anatomic bypass for the celiac, what was your location? Was it aorta celiac? Was it iliac to celiac? Or was it other? And you've got a few extra questions down here under these questions. Just wanting to know the type of extra anatomic bypass that was used. Okay, so once we get through all the arch branch and the abdominal branch, the visceral branch by management, then we move into was this a planned stage hybrid, which we kind of already talked about before, where and sometimes this can occur in a different episode of care too. It can occur like you know, a week here and then a week later it might occur. It's still hybrid. You'd still want to code that because it is part of a planned stage hybrid. But most often, a lot of times you'll see it in the same episode of care. So they'll do the arch branch management first. A couple of days later, they'll do T-bar. So some other endovascular procedure information that we would like to collect on this. Dissection of the proximal entry tear covered. So that's a mouthful. What does that mean? So basically, we want to know whether the proximal entry tear was covered. And is it fully covered by the aortic endograft? So the so-called primary tear of the dissection, is it fully covered by the aortic endograft? If yes or no. The second thing we want to know is there an endoleak at the end of the procedure? And we talked about endoleaks a little bit a couple weeks ago, but basically it's an endoleak is defined as persistent blood flow in the aneurysm sac through and around the seal. And it's really the most common complication after an endovascular aneurysm repair. So if there is a leak, what type of leak? There's some really nice diagrams in the training manual that'll be carried over, but we have a type 1A. So that's a leak that is defined as a leak occurring in the proximal seal zone. Or we have a type 1B. That's the endoleak that's defined as a leak occurring in the distal seal zone. We have a type 2A. 2A type 2 is an endoleak defined as a retrograde filling of the aneurysm sac or false lumen. A type 3A endoleak is defined as leakage of blood into the aneurysm sac or false lumen in the case of dissection, due to either a gap between separate endograft components or defect in the fabric. We've got some nice pictures here in the training manual, currently in the adult training manual. Type 4 is an endoleak. It's defined as the presence of an endoleak secondary to a graft persistity. All other types of endoleaks must be definitely ruled out prior to selecting this type. This is where your surgeon comes in, and it's very helpful to help you to identify what type of leak this is. And then we have a type 5A, known as endotension. It's defined as persistent aneurysm expansion in the absence of a confirmed endoleak. So again, definitely you need surgeon involvement to help you to determine the endoleaks most often, because the types, unless it's just pretty straightforward, not always clearly documented. So again, if you can encourage your surgeons to use the aorta worksheets, that would provide you with much more information. Then the next question we want to know about these endovascular procedures is, was there a conversion to open? So for some reason, did we have to convert this endovascular procedure to an open procedure? And if that happens, what was the reason? Was it because the deployment failed? So couldn't get that endovascular stent placed properly, so you had to convert to open? Or was there a persistent endo leak that the surgeon wanted to fix before he left the operating room, so he had to open him up? Or God forbid, the aorta ruptured. That's a really bad reason to have to convert. Or did the stent deployment produce some sort of occlusion or loss of a branch, so that you needed to open that patient up and fix that? For example, if it was like the renal artery, you want to fix that so the patient wouldn't have kidney failure or something. So just things like that. So it asks you the reasons why you have to convert to open. The next question is, did an intra-op dissection occur? So basically what this means is that that's the section that you already have, because a lot of times these are done for dissections. Did it extend, or if you didn't have a dissection to begin with, this was just for an aneurysm, during the procedure, did a dissection occur? And if the answer to that question is yes, dissection occurred or extended, then what did it extend? Antegrade, which means downstream toward the descending or abdominal aorta, or retrograde back towards the aortic arch or the ascending aorta? Or did it extend both ways, back and forward? And then the last question we want to know about an endovascular procedure is, did you have an unintentional rupture of the dissection septum? Again, this is a bad thing. I don't see this very often. But the intent is to capture those instances where the dissection membrane or septum is unintentionally ruptured during an endovascular repair of an aortic dissection. So this is an unintentional rupture. And sometimes the surgeon may elect to intentionally rupture this by using a balloon. So this sequence number here, 4190, is just for unintentional. Oops, I did not mean to rupture that septum. And if there is a rupture, where did that rupture occur? Which zone? Where was the location? So as we move through, now we're getting into, we've pretty much got through all of our types of procedures. Now we're coming into a section where we have some questions for all the aorta procedures. So all the questions would have answered these questions. So spinal drain placement. So was there a spinal drain placed to drain CSF fluid? Sometimes this is used as an adjunct to protect against paraplegia during your aortic repairs. So if they placed it, was it pre-aortic procedure or post-aortic procedure, or they didn't place it at all? The next question has to do with intra-op motor evoked potential. Was that measured? So motor evoked potentials are used to monitor spinal cord function during aortic intervention. So monitoring involves direct monitoring of electrical impulses used to stimulate the motor cortex and measurement of the response along the spinal cord. So you may see some changes in the function during an aortic procedure that could indicate spinal cord injury. So that's why a lot of people do monitor this motor evoked potential. So if that was used, we want to know yes or no whether you used it. And if you did use it, was there an abnormality noted during the procedure? The next question is intra-op sensory evoked potential. So this is used to monitor spinal cord function or sensory function during aortic intervention. So again, you're monitoring electrical impulses used to stimulate sensory tracts and measurement of sensory response along the spinal cord. And if you use this, was there a documented abnormality? And I'm sure you're seeing a trend now. You can have spinal cord injury during some of these procedures, these aortic procedures. And so this is why this monitoring is in place and used. The next question is, did you do an intra-op EEG? And the EEG is used to monitor your overall brain function during thoracic aorta procedures. This is not the same as BIS monitoring or bispectral index monitoring. This is an intra-op EEG. And if you use an intra-op EEG, did you have an abnormality noted? Now, just to note that if you use an intra-op EEG in a circ arrest case, the EEG is going to say documented as isoelectric activity. Is this coded as yes for a documented EEG abnormality? Well, no, because you are under circ arrest. So in circ arrest, an isoelectric EEG is abnormal, but it's normal for people who are in circ arrest. So again, a lot of neuro type of monitoring for these procedures, because a lot of these abdominal procedures go on, not only can you injure the spinal cord, but a lot of them are under circ arrest, especially arch procedures. And so you want to also monitor brain function because you can have adverse events from these types of procedures. So that's why we're asking these questions about all of this additional monitoring. The next question is intra-op intravascular ultrasound. So this is IVUS basically. So the use of IVUS during the actual aorta procedure is it's using. So sometimes they use IVUS to do a percutaneous placement, like of the stick. That's not what we're asking for. We're asking for, was IVUS actually used during the aorta procedure, not to just obtain access. So IVUS is sort of like, it's a unique point of view. It's kind of a picture. You can go in and kind of get an idea of what the vessel looks like. It's kind of imaging of that vessel. They use IVUS a lot in the cath lab for coronary vessels, but you can also use IVUS intra-op for your coronary vessels in your aorta. So the next question is intra-op transcutaneous Doppler. So a transcutaneous Doppler enables the surgeon to alter his or her approach depending on the size and location of any kind of aortic atheromatous burden or this calcified burden, so that it provides an opportunity for guidance during cannulation, cross clamping, and aortotomy. So did they use that? The next question is, did they do an intra-op angiogram? So most often this is sort of post-procedure because they're inspecting the anatomic results of the surgical procedure. So did they do one? And if they did one, how much contrast did they use and how much fluoro time? You know, sometimes it can be during the procedure, but a lot of times it's done after to see what the job was done. Did it do a good job with this? And then endovascular balloon fenestration of the dissection flap. So indicate if endovascular balloon fenestration of the dissection flap was performed. So if you had a dissection flap, did you do a balloon fenestration of this dissection flap? I don't, you know, that's not a, I don't think it's very commonly done, but it can be done. And if it is done pre-op, intra-op, post-op, or not applicable, we didn't do it. Now we're going to get into the devices inserted. How much time do we have? Okay. We don't have any questions, right? I can't.
No, ma'am, nothing yet.
Okay, good. Okay, good. So we'll go ahead and move into devices. So maybe we can get through with this aorta section today. So aorta devices inserted. Now, you have to remember that this aorta section encompasses procedures that are combined aortic valve and aorta procedures and just aorta procedures. So the first question it asks you is, was there an aortic valve or aortic valve composite graft implanted? Yes or no? So these are like your Bentals commonly. So you may have an aortic valve and then a separate graft, or you may have just a composite graft planted. If this is a commercial valve or a commercial composite valve conduit, then you're going to pick your implant model, your implant size, and your UDI, if applicable. We don't really recommend people typing that in. We prefer you either copy paste it in because the number is very, very long. If you manually type that in, there's a lot of room for error. So that's the first section. Okay. The second section, if you scroll down just a little bit, Leanne, is we're going to get down into a section where we're talking about actual devices other than aortic valves and aortic valve composite grafts. Okay, so if you're just doing like a Medtronic freestyle, you know, Bental, it's all valve conduit, that's all going in the above section we just talked about because that's a commercial graft. And it involves the aortic valve. Now, down below here, kind of lost my screen. There you go. Down below here, we're going to talk about stuff like Hemoshield grafts, okay? Or, for example, if your surgeon put in an aortic valve, but then he decided he was going to make or sort of make his own valve conduit. So he's using a Hemoshield graft and kind of putting those together to make a conduit. So down here below is where those Hemoshield grafts go. I know this can get confusing. I'm trying to break it down as easy as I can, but I understand that this is confusing. So down here, we're going to first want to know the implant method. Okay, so was this open surgical or was this endovascular? Okay, so these are grafts that go into the aorta. Outcome. Was it successfully implanted or deployed? I mean, unsuccessfully implanted or mal-deployed. Was it implanted, deployed, and removed? Or was it successfully implanted and deployed? So you've got three choices there. Then we want to know your model number. You have to type that in. And your UDI, again, this is not your serial number. This is your unique device ID number. We recommend not typing that in. It's very, very long and lots of room for error there. So, trying to think if there's something else I want to say here. So, oh, aorta device, need to say this. So, for when we ask for people to code the devices that go into this section, so these are not your commercial AV or your aortic valves or your commercial valves conduits. These are like your Hemoshield grafts. So we asked for people to enter the proximal side of the graft and the distal only. So for example, if you have a graft that goes from the mid ascending down to the descending, or it's probably not a good example. I'm trying to think off the top of my head. Let's say you have an example. It goes from zone 1 to zone 3. So you would put zone 1 in, so that's your proximal, and then you'd enter your distal zone 3. So basically, you're entering the same graft in twice. And the reason we ask for you to do that is because when we look at this and analysis, we'll be able to tell, okay, so the first implant was here in zone 1 and it went down to zone 3. So you can see the coverage of the particular area in the aorta. So you're entering the proximal site and the distal site. So you're basically entering the same graft twice. We don't ask for you to enter the middle area. So, because this is zone 1 to zone 3. So you don't have to enter zone 2, but you got to enter the proximal, zone 1, and the distal, zone 3. So the coverage of the area in the aorta. Again, we'll talk a little bit more about aorta devices. So again, when we talk about device, it refers to any implanted material within the aortic valve for combined aorta and valve procedures, and the aorta. So this is grafts, stent grafts, could be Dacron, could be homograft, could be autograft, could be stent graft. But it's in the aorta. So like if you're doing arch branch reimplantation, or you're doing an arch branch stent, so those stents or those grafts that are going into these arch vessels that are not in the aorta, they're off the aorta, they're not in the aorta, those things don't go in the device section down here. This is just stuff that's planted in the aorta. I think that we're just about done. Unless we have questions or Carol thinks I need to go over anything else, I think we're about done with the aorta section. It's a lot.
It is a lot. People's heads are swimming. I'm trying to process everything.
Yeah, my head's swimming too. It takes a lot. This takes a lot. And it takes a lot of practice. And I've been doing this for years, and like I say, I still struggle with some of these myself. So I understand that this will make your head swim, because it still makes my head swim sometimes. Okay, so it looks like we've got a little bit more purple here. It looks like we have a question. Let's see what the question says. So a TEVAR graft of the right SCA to carotid, would you put the device under the devices? No. So if the graft isn't from to the right subclavian to the carotid, that doesn't go in aortic devices. That goes into your arch branch management. We have a pretty good picture, like page in our training manual. It's page 333 of what to capture. And
what's the sequence number?
it's under 5440. Keep going a little bit down further. It's a nice little picture.
Right here.
So here you can see where you got your down here starting just right above the root here, you got your graft going into your aorta. Okay, so this is a device that's captured in aorta devices. Coming off of this, you have an arch branch. This is arch branch reimplantation. This device does not go into the aorta section, okay, because it's not implanted in the aorta. It may touch a little bit, but it's not in the aorta. It's connected to it. So this section, this graft up here, just goes into arch branch reimplantation. I think that's a pretty,
Yeah.
I have to thank Mitali for sending me that picture. That's a great picture. It's nice.
All right. Yes, you have, I'm echoing what Dr. Jacob says. You've done a great job
Thank you.
today. You've done phenomenal. And I'm hesitant. It's already 10 till, so I'm hesitant to go ahead and start the post-op section.
That's great.
So I'm just gonna wait and see if there are any questions come in, unless kind of waiting. I don't know. I know I think Carol had to step away, so she's not available right now. But I don't know if anyone from the panelist side had anything else that they wanted to add for today, because I like I said, I'm hesitant I don't want to start the post-op section because this was a lot to consume. It's very complicated, and I know everyone's brains are probably like, oh my God, what just happened? So
This is Kathleen and Melinda. I was listening. I had to fill something out, but I'm listening and I'm like, oh my gosh, Melinda is so good she knows this section so well, and I learned so much every time you talk about it. So I think you did a great job too. So thank you very much.
Thank you.
It's good to stop here, Leanne.
yeah, and here, let me pull over the slide deck. So I know that, like you said, this is a lot that we just covered, and well, that Melinda just covered. So you have it. If you have additional questions, we're going to have additional Q&A times. We'll do the post-op events on our next call, the post-op events. We go through patient process measures and then finish up with the anesthesia section. So again, we'll have these additional webinars. So if you think of questions, just jot them down, bring them back to these additional Q&A times, and we'll happily get those answered for you. So just take all that back, process, and jot down your questions, and we can get those answered on our additional Q&A webinars. And I think we had also talked about on those Q&A webinars, do like a case scenario, Melinda. I think we had discussed that after our last webinar. I think that would be a good, a good example, just to do a case scenario and walk through that on one of these extra webinars as well.
Yeah, just let me know, and I'll have my handy dandy friend who does all our aorta education. I'll get her involved in it. She does wonderful presentations, and I'm sure she'd be happy to do aorta presentations, and I'm happy to do help with that. And also, if there are other areas that people are feeling uncomfortable with, that they may want a presentation or a scenario, if you could just relay that to Leanne or Chastity, so that we kind of know where to focus efforts.
Yeah, that would be great. Excellent. All right, I'm not seeing any additional questions come in, so I guess we will wrap it up a little bit early today, and we'll pick up on our next call. We'll start kick off with post-op events.
Great.
So great job today, Melinda.
Thank you.
Melinda, thank you.
Yes.
Yeah, that was a great job. Thank you. Thanks, Leanne. Thanks, Chastity and Janet and Leslie, everybody, and Dr. Jacobs for joining.
Yes. Thank you. Thanks,
Great.
guys.
All right. Have a great day.
All right, you too. Thanks, everyone.
Picture of Hank as people hang up. Of Hank as people hang up.
Yes.
Let's see a little Hank. Get that sweet
little
face. He's so cute.
He's such a good boy.
How much does he weigh right now?
About 10 pounds.
10 pounds.
Mm-hmm.
I'm gonna need a FaceTime call with Hank.
I know. I feel the same. He can write.
He's so cute. I just want to squeeze his little face.
Yeah.
I'm coming over when I'm in Chicago, Carol.
Yeah,
We
please do.
play with this dog.
All right, thanks,
All
everybody.
right. Thanks,
Bye.
everyone. Chat soon.
Okay, bye.
All right. Bye-bye.